So we're now going to look at the obturation of a tooth with an open apex. This is a maxillary central incisor and has been prepared to a size 100 at the apex, and the question is often asked what size should be considered an open apex, and it's difficult to give a direct figure, but an arbitrary figure would be anything a size 70 or above should be considered an open apex, and that's just in practical terms. If you look at older definitions of the open apex, some people would regard it as anything 100 and above. The difficulty we face is that many of the rotary systems end at a size 50 at the tip, and so we have an area between a 50 and a 70 that's neither one thing nor the other in terms of it being a closed apex or an open apex, and that's a decision that needs to be made clinically. We are going to obturate this tooth using MTA apically, followed by a gutta percha backfill. And to do this, we are going to need a number of different items of kit. The first being an MTA carrier, and you can see this is one of the disposable carriers from QED, and we've chosen the orange color. This is pre-measured, but pre-measured to a length 2 millimeters short of our working length of 19.5 millimeters. The reason for that is that when we expel our MTA from this carrier, you can see where it will come out. It's going to be about 2 to 3 millimeters in length, so we don't want this placed directly at the apex, because if we do, when we compress it, it will extrude out apically. Extrusion of MTA is not a major issue due to its biocompatibility, but radiographically that's not the result we are aiming for. We are also going to need a number of pre-measured pluggers, and these are just our standard MASH 2 pluggers, and you can see this again is measured 2 millimeters short of our working length, and this will be to carry our MTA down towards the apical region of the tooth. We can use varying sizes and tapers if we need to. And the final thing we will need will be a series of pre-measured paper points of size 70. And these again will be measured to 17.5 millimeters and will be passed directly over to you by your nurse and used essentially to compress our MTA into the apex. My preference is for the first increment of MTA to be mixed slightly runnier than the others, and also for that increment of MTA to be packed against the apical region. Now remember, there is a certain amount of resistance to be offered from the granulation tissue within the periapical radiolucency, or from any tissues in the apical region, and so if we're not overly aggressive with our packing technique, we don't need to be overly concerned with the extrusion of MTA out through the apex. So the first step, as I say, is to carry our first increment of MTA down into the apical region of this tooth, and I'm just going to increase the magnification here, so hopefully you will be able to see into the apical portion of the tooth. And we can see that this is our pre-prepared canal with, albeit an artificially enlarged access cavity, and we now have our first increment of MTA in our disposable carrier. This is positioned in and down towards our reference point, but remember, we are not necessarily carrying this right down to working length. And also, if you cannot find a carrier which binds 2 millimeters short, don't worry, because you will have the ability to compress and compact this MTA down towards the apical region. We expel our first increment of MTA, and we can pass that instrument back to our nurse, who will then pass us a size 70 paper point. We will then gently compress our MTA down towards the apical region of the tooth, and this is a runnier mix, remember, and all the while the MTA is becoming a little bit harder on the mixing pad. Don't worry, you can always reactivate this by putting some fluid into it afterwards, and you can see I'm just circumferentially packing down into the apical region. If you feel that you need to put a little bit more pressure, or you feel as though your increment is not traveling down to your full working length or to your desired length, you would then go back to one of your MASH 2 pluggers, which is pre-measured, and you compress down apically. Once that's done, you receive your second increment of MTA, and remember, you do need this to be at least 3 millimeters in thickness upon completion. You put your carrier in, you put your next increment in, and interestingly you can see how the instrument almost pushes itself back out of the cavity, and we take another paper point And again, this is measured and we compress gently down. And you can see the action. It's just a very gentle compression. There's not a lot of pressure being put on there. At this point, we will take, and this is an incredibly quick exercise. We don't need to spend a lot of time packing this MTA down there, because our working time, depending on the type of MTA you're using, can be as little as 12 minutes. And so we put our further increment in, and at this point we expel that out, and we take one more paper point and we gently pack downwards, pack towards the apical region. And now if I tilt this towards you, you can just see within the root canal space the appearance. If I put the paper point in, you can just identify where the root canal is, and you can see the layer of MTA apically there. Depending on the root anatomy, this may be a sufficient amount of MTA, or you may need to put further increments in, and you would of course confirm this radiographically. If after radiographic confirmation you were short of your desired length, you would then get again a pre-measured MASH2 plugger, and you would gently compress the whole increment of MTA down towards the apex. Now this needs to be done in a very controlled way, and you can see I'm just gently compacting, and you could equally use one of these instruments in order to pack the MTA down towards the apical region of the tooth. The choice between paper points or using a matched measured plugger is entirely up to you. Again, depending on the type of MTA we are using, at this point or later, potentially at a subsequent visit, you are ready to backfill your tooth, and this will need some sealer to be put into the root canal space first. This needs to be mixed in a relatively runny fashion in order to adapt it to the walls. But before we complete this, we will need a micro brush with a little bit of water on it to remove any remnants of MTA from the coronal portion of the tooth, and also from within the root canal. And you can see the cavity looks much cleaner having done that. So we have just cleaned that from our coronal portion, because we don't want the unexpected and undesirable complication of having a discolored coronal portion of the tooth after our treatment. We re-dry our canal and we confirm that our MTA plug is in situ, which it is, and we then carry our aforementioned runny sealer into the root canal space. And once that's in and we're happy with our adaptation, we then go to our backfill. Now our backfill of this tooth, you need to be quite careful, because in some situations you can backfill the whole canal quite readily in one increment. However, the adaptation of the initial increment of gutta percha onto the MTA can often be difficult, and not correctly doing this will result in a void between your apical portion and your gutta percha backfill. So what we need to do is we need to expel our first increment of gutta percha into our cavity, and we need to correctly compress this down onto our bed of MTA that is located apically, essentially. So we've got our backfill, and again we position this in, and don't be afraid that you're going to extrude this. This will rest against your bed of MTA apically. You pull your trigger and we will start to see some orange potentially appearing in the canal here. You take this out, and we will then compress down onto the gutta percha that we've put in there. And I can't stress enough that this first increment of gutta percha should always be packed before you backfill the remainder of the canal, in order to ensure adequate adaptation between it and your MTA apically. Failing this, you will end up with a void, which will be disappointing radiographically and can potentially affect outcome. Once the first increment is in, the remainder of the backfill can be done in one increment if you choose to, and again we wait to allow it to push us out of the canal. We're not pulling it out because we don't want a void. And you can see the GP extruding coronally. We take away any excess, which can be done either with a System B or an equivalent, or even, as I did just there, with the tip of the backfill itself. And we then compress down, and you can see that we have got our gutta percha into the coronal portion of the canal. At this point, we would of course clean the coronal cavity with some alcohol on a microbrush in order to remove remnants of sealer. We would etch prime bond, and we would put a well adapted and well fitting composite restoration. And we would remove our tooth from the block today, and we take a look just to see laterally, of course, what this looks like. And if we look, we can see that we have got our, let me just reduce the magnification slightly here. We have got our gutta percha in the coronal portion, and our MTA down in the apical portion of the tooth, and a nice dense fill. You can see as I rotate it, we have got adequate adaptation and the distinct difference between the two materials.